This is Dr. Jamie Kaufman, and this is Dr. Kaufman's Acid Reflux Hour. How do I know if I have silent reflux? Maybe one of the most important questions in America for people's health. It would be my opinion that 100 million people have silent reflux. So I'm going to discuss that. I'm going to talk about it. When we say silent, what do we mean? Ordinarily, people think of heartburn, indigestion, crushing chest pain after a greasy, heavy, shouldn't have had that third hot dog meal. And it's something the GIs have pretty much popularized. It's the heartburn business model. So they stick scopes down people and put them on Nexium. And so that's pretty much the model that they've dealt with for 50 years. During that time, I've published an extensive amount of work on respiratory reflux, which is a new term for LPR. By the way, terms mean something. In 1987, I was doing reflux testing on my patients with laryngeal and voice problems, and they didn't have heartburn, they didn't have indigestion, and their profile was different, and the reflux testing was different. So I came up with the term laryngopharyngeal reflux, or LPR, because that's what I was doing at the time. But just so you know, that term is difficult to pronounce, and it's archaic. It's incomplete. Respiratory reflux is much, much better. Anything up here can be in the respiratory system. And as you'll see in a moment, I'm going to talk about shortness of breath. Certainly that's not laryngopharyngeal reflux, that's respiratory reflux. So, in other words, reflux can affect any part of the respiratory system, including the sinuses, the ears, the nose, and breathing, as well as the trachea, bronchi, and lung. The term silent reflux is a funny story. It's about 30 years ago. The head of anatomy was a lovely man, always wore a bow tie, always smiling, and always smelling of formaldehyde. And he came to see me as a patient complaining of hoarseness. He was having trouble teaching because his vocal cords were very raspy and heavy, and to me sounded swollen. I examined him, and he had respiratory reflux, or LPR. And so I explained, you have reflux. And Walter said, no, I don't. I said, yes, Walter, you have reflux affecting your throat and your vocal cords. He said, no, I don't. So I said, wait a minute, Walter, you think reflux, acid reflux, is heartburn, and you don't have any heartburn. He said, that's right. So then he thought, and he looked up for a while. He said, I see. I have the silent kind of reflux. And I said, yes, Walter, you have silent reflux. So that term goes to Walter, and if he's ever seeing this, thank you. It's a great term. It also, unfortunately, is silent to your doctors. As you've seen, I've done a fair amount of gastrointestinal specialist bashing on this platform. And the reason is that they don't understand anything about respiratory reflux. They don't have any test for it. They don't have any treatment for it. And if they're the go-to doctor for reflux, then what's the poor ENT or pulmonary doctor to do, or your family doctor to do? So it's not only silent because you don't know what's happening, perhaps, and it's also silent to your doctor. Let me give you a good example. Over the course of 50 years, as part of the intake form, people are asked if they have asthma. And if the box asthma is ticked, I ask the question, say, when you have an asthma attack, do you have more trouble getting the air in or out? And 4 to 5, 80% go in. So if you have trouble getting in, it's not asthma. Never, ever. Okay? Asthma is when the tubes in the chest get all congested and you have to squeeze the air out of the lung during expiration. So understand that this is an example, $80-something billion for asthma treatment, $55 billion of it's wasted because it's not treating. And by the way, the same group of patients say, when you ask, does the asthma medicine work? They go, oh, no, maybe a little bit the inhaler. And an inhaler can help even a little bit with respiratory reflux. And I think you should get used to the term respiratory reflux, by the way. And I think we should get rid of the term GERD. GERD is a wastebasket. That's like saying motor vehicle. Well, what about cars and planes and buses? So as it is right now, there clearly are two distinct types. Not that you can't have both, but respiratory reflux is usually silent and occurs at night. Silent, nocturnal, respiratory reflux. Snore, S-N-O-R-R. And then there's esophageal reflux. And the term GERD ought to become extinct. By the way, LPR, which is the term in the literature, please, as we go forward, use the term respiratory reflux, my colleagues, because it's it's much more intuitive, it's much more comprehensive and accurate. So, Walter Bowe, thank you. What I'm doing is, I do consultations. I do them every Sunday from 10 to 12, and I do them Monday in the morning and afternoon. And so each of the people, the consultees, the patients, fill out a very extensive form, and a lot of questions are asked. And one of the questions, all the questions about reflux symptoms are asked, from heartburn to globus, the sensation of a lump in the throat, to too much mucus, and so on. And so I did a prospective study. It's not done yet, so I'm not going to publish it. But I've been looking at keeping the data. After I finished doing the consultations, I would go on to an Excel spreadsheet and put data. And what I found was staggering. So just so you should know, and by the way, if you're hearing this gastroenterologist, wake up. The number one symptom of respiratory reflux is postnasal drip, and I included too much mucus and chronic throat clearing. It's all the same thing. Thick mucus. Why? Respiratory system lined by mucous membranes, and if you have irritation, the mucous membranes, mucus makes more mucus. So it's thick mucus. It gets on your vocal cord. And that allergy doesn't do that. Allergy is thin. So if you have allergy diagnosis and it's thick mucus, you may not have allergy. By the way, a lot of people have both allergy and reflux. So in 76%, 3 out of 4 have postnasal drip, too much mucus. The staggering and really surprising result was the second most common symptom of respiratory. And by the way, this is a biased sample because people are consulting me because they've already decided they think they have respiratory reflux. And by the way, I can't examine them, but their profiles and their stories are such that they could only have respiratory reflux. And as you'll see, there are some symptoms that really are rather pathognomonic, really could only be respiratory reflux. So shortness of breath, I'm going to talk about in a minute, 48%. The third most common symptom is globus, a sensation of a lump in the throat. This is a little iffy because I can't always tell whether they're talking about mucus or actually feeling like something's down there. If something's down there, it feels like a lump, ask yourself, do you notice it when you're actually eating? And if you do not, then it's probably upper esophageal sphincter, a misbehavior secondary to reflux, and it'll go away when your reflux goes away. And the same is true of difficulty swallowing. So we've studied this, and reflux makes that upper valve really crazy. It closes during the middle of the swallow. So these are symptoms of respiratory reflux. At 35% is dysphonia, which is voice problems. And it doesn't matter who you are. I mean, if you're a cabbie and your voice is raspy in the morning, you're probably not so concerned. But if you're doing 8 shows a week on Broadway, dysphonia is number one symptom. Checking in at number 5 is a chronic cough, 23%. And finally, we have heartburn at 24%. And believe me, I pressed people. And I said, well, do you have it sometimes? When I change my med. So 24% is as big a number as I can make by probing and asking questions. When the circles can be from 0 to 5, and if there's a 2 or 3, I ask, is it heartburn? They go, no, I feel stuff coming up, or I burp a lot. But 24% means that if this data is important data, that 3 out of 4 people with acid reflux don't have heartburn and have silent reflux. Now, silent reflux occurs at night while you sleep. It's silent nocturnal respiratory reflux. In America, we eat late, It's our big refueling meal of the day. That's how we entertain. Think of the cookout with the hot dogs, hamburgers, beer. You know, getting late now. You guys were eating till 9 o'clock, and then you got home and you were in bed at 11:30. So you're going to bed with a full stomach, full of fatty stuff. You really have to reflux all night. There's really no alternative. But you don't wake up. Now, for those of you who wake up, if you wake up in the middle of the night coughing and sputtering and have a choking episode, you move yourself up into the championship division of refluxers. And so understand that waking up in the middle of the night with symptoms is definitely, and by the way, disrupted sleep is often related to acid reflux of this type. And how do I know that? Because I've listened to patients for 50 years. And one of the things I found surprising that I learned earlier on is that people say that their sleep is much better now that their reflux is under control. So those are the most common symptoms. I want to give honorable mention to pneumonia. If you're basically an otherwise healthy person who's not immunocompromised and you have pneumonia or pneumonia more than once and you're not very, very sick and hospitalized, that's reflux. That's a reflux aspiration event. In fact, I think it's one of the most common ways that people in nursing homes die. There's a regulation that has been interpreted that in nursing homes, the older adults should receive a snack if they want, and they get chocolate pudding and ginger ale, and at 3 o'clock in the morning, chocolate and ginger ale are in their lungs, big aspiration event, and they die of chocolate pudding, a ginger ale pneumonia. I've said this before, but there should be no snacks for people before bed, for anyone, especially the elderly. So, COPD, I don't think you can get COPD from smoking alone. I think you have to have reflux. I think, and by the way, if you are on this site and you are not signed up for my blog, jamiekaufman.com, and you are not using it as a resource, shame on you. I have 5 questions about hiatal hernia here. You go on the site and you type in hiatal hernia, and up pops an article. And what does it say? Not important. People can have reflux without a hernia, and people can have a hernia with no reflux. So it's not a deal breaker. It was in the 50s. We said, ooh, hernia, operate on it. None of that's true. We don't do that any further. So difficulty swallowing, I mentioned, it's right here. What happens is the upper esophageal sphincter closes in the middle of the swallow. And that will get better when the reflux gets better along with the globus. And often they go together. Nasal and sinus symptoms, people can complain of nasal symptoms, particularly congestion in the morning when they wake up. Remember, supine, lying down, nocturnal, nighttime, respiratory reflux. So if you have symptoms in the morning when you wake up, you have it. Okay, and if you go on the site, you'll type in snore, but it'll be SNORR. And so I think SNORR affects 100 million people. How? Well, I already told you about the millions of asthmatics. What about people with COPD? The case that I present on the site, type in COPD, is a man who could barely get his oxygen from my waiting area into my office, quit smoking 25 years ago, was having severe progression of his COPD, and didn't look like he was going to be around much longer. His PhD study was prize-winning. He had reflux like 90% of the time. I'm talking about respiratory reflux, day and night. And so we changed his diet, we changed his lifestyle, we changed everything. And his reflux got well. And he threw away his, he didn't throw it away. He stopped wearing his oxygen all the time. He put it in the car, and he drove himself to Florida to go to Met spring training. And if you're listening to this, good luck. I hope you're still doing well. And the same with chronic bronchitis. Read those cases. Those are the exception that make a rule. So chronic bronchitis, lung problems, you're not a smoker, and secondhand smoke, in my opinion, and air pollution are not enough to cause. I'm writing a section on cancer and reflux for the book, my book, Respiratory Reflux, and in my opinion, you can get cancer without smoking, but not without reflux. And we know now pepsin, which is the bad active enzyme that causes inflammation, also causes cancer. It's found, for example, in Barrett's esophagus, and it's found in all the biopsies we've ever taken of laryngeal cancer. So, in my opinion, you can get cancer without smoking, but not without reflux. The reflux is a key variable. And by the way, that gets to the other symptoms. You know, you have to reflux, just have the silent nighttime reflux for 10 or 20 years to start snoring, ladies. Ladies aren't snorers. I don't know why. But sleep apnea is reflux, okay? When I was a kid, let's go back to it, okay? I'm talking about 1960s, before McDonald's. We didn't have any diabetes. There was one diabetic friend, one asthmatic kid. There was no obesity epidemic, one fat guy. And so all of the diseases, we spent $1 trillion a year to get sick. And then we spend another $1 trillion a year on silly remedies that make people, venture capitalists or whatever, a lot of money. So don't ask me, but I'll tell you, do not get TIF procedures, do not get LINX procedures, do not get partial fundoplication procedures. When it comes to reflux, there is no better doctor, better pill, or better procedure. And the only way to beat reflux is to go through a period of abstinence, of saint-like adherence to a detox program, which has many facets, and I'll just list them quickly. Really, really early eating, really, really high sleeping, low acid, low fat diet, famotidine, Gaviscon advance or its equivalent alginate, and gum chewing or candy after every time you eat. And if you look at all those things together, each one acts a different way. Alginate rises to the top of the stomach. So you have to do, and you have never, you're done. You're never going to go to McDonald's again. All right? Forget about Chick-fil-A unless you want to have the grilled one, which doesn't taste so great. So fast food is done. Now, in Jamie world, I'm older and I do a lot of cooking and I do a lot of entertaining. But I've also learned how to cook, which is I do a lot of more stuff than I need, so that I could take the extra anytime, particularly things like salmon, baked potatoes, and so on, and have them. I have a lot of food in the refrigerator that you say it's leftover night, but leftover night's pretty good. So the answer to the question, and all these little questions, they're annoying to get questions that must have come from Facebook, that are so ridiculous about things that help reflux. So there were ear symptoms too. Read the article on ear, read the article on sinus. People who have a mucoperiosteal thickening, meaning on CT scan, all the sinuses have thick lining. That's not sinusitis. You should not have surgery. Too much sinus surgery being done unnecessarily. Now, it gets back to the question of how do you get rid of reflux? And the answer is, if you can stop the reflux 100% for a month or so, why won't it heal? The lower esophageal sphincter is the main gate, and it's inflamed and stiff, and reflux is self-sustaining. The more you reflux, the more you reflux. More inflammation. So understand that these little things, people say, what about DGL? DGL would be like pissing in the ocean. Okay? No effect. And most other things. And I can tell you one thing, don't have a LINX procedure. I have a ton of people consult me of LINX procedures. They're hard to remove if you do need fundoplication. And even though they're not common, some of the complications, erosion complications, are really deadly. So I'm not a fan of the magnets. So, talked about a lot of symptoms, but I want to go back to shortness of breath before I quit. When somebody ticks the box shortness of breath, I ask the following. I say, well, there are at least 3 kinds of shortness of breath. The first is on exertion, type 1. You run up 2 flights of stairs and you're huffing and puffing. Really, 2 flights of stairs. You should not be huffing and puffing or with exercise. So exercise-induced shortness of breath. So that's type 1. Type 2, Kaufman sign. is difficulty or discomfort taking a full breath in. And the mechanism for that is completely unknown. It's vaguely mediated. Everything's vaguely mediated. You don't need your vagus treated. If you have heartburn, it's vagal. If you have a cough, it's vagal. If you have a sore throat, it's vagal. And if you have difficulty breathing, with normal chest x-ray and normal pulmonary function, it's vagal. It's vaguely mediated. We don't understand the mechanism, but that inability to take a full breath in, 63% of people with shortness of breath had that. And some of them just had that. So I said you have number one, number two. Number three is airway obstruction, trouble getting air in and out, asthma and pseudo-asthma examples. And just so I finish properly on that one, again, I want to repeat, if you have trouble breathing in during an asthma attack, it's not asthma, it's reflux. So there are other causes. You can have acute attacks of choking, where you can't get any air, and you can have a paradoxical vocal fold movement where it goes on for an extended period of time, all reflux caused. If you go to the speech-language pathologist for therapy, that may help, but the underlying problem is still reflux. So the reason why I say there's 100 million people, if you add the COPDs, the chronic bronchitis and emphysema people, and you add the people with sinusitis who don't really have sinus disease, and you add the people, and what's happening is, you have asthma, and neither you nor the doctor know the problem is reflux. And actually, to make matters worse, if you have real asthma, studies show that 77% of asthma attacks are triggered by respiratory reflux. Sue Harding, Birmingham, Alabama. So I'm going to, next week's blog is going to be this topic: how do I know if I have silent reflux? And this is the, let's see if I can get it on here. This is the reflux symptom index. I came up with this, in the 80s, and it's a validated instrument for doing research, and has been now for a long time. And you ought to look at it, and it goes again through the things we know: hoarseness, throat clearing, excess mucus, difficulty swallowing, coughing after you eat, breathing difficulties, a troublesome, annoying cough, sensation of something sticky in the throat, heartburn, chest pain, and so on. So, if you have an unexplained breathing problem, chances are overwhelming it's respiratory reflux. And to finish on this, it's silent because neither you nor your doctor necessarily know it's reflux, because it occurs at night while you sleep, even though your symptoms may be during the day. So there you have it: silent nocturnal respiratory reflux. Y'all have it. And a lot of these questions I'm reluctant to answer, because again, this is like, the ship is sinking. If I tighten the screw a little bit, you think it'll help. And so these are all so marginal for you people. And I'm going to get to one question where I'm gonna yell at the question asker. So to questions. I've had silent reflux for years. I now have Barrett's esophagus and hiatal hernia. Okay, I got to talk about Barrett's esophagus for a moment. In my practice, doing transnasal esophagoscopy, for every 3 patients who came to me with Barrett's esophagus diagnosis, 2 of them didn't have it. And I think here's why. Everyone has an irregular Z-line, like little pre-Barrett's. We all have it, pretty much. Hardly ever do you see a normal junction where the esophagus meets the stomach and it's a completely round. There's always a little irregularity. But what happens is they take a biopsy. They're told to take 4 biopsies with big cup forceps. After the first biopsy, there's blood everywhere in the field. They have no idea where they're taking the 2nd, 3rd, 4th biopsy. And if they go a little low, they see goblet cell metaplasia, and they call it Barrett's. So one thing you can do is make sure you have 2 documents. You want to have the endoscopy report, and then the biopsy report. The endoscopy report will describe mild inflammation, irregular Z-line, otherwise normal, and that's not Barrett's. Barrett's a clinical diagnosis. So if it's not described in the endoscopy, and then it comes back as Barrett's, you probably don't have Barrett's. Hiatal hernia, 2 centimeter hiatal hernia is of no clinical relevance. I've said it several times, not important and doesn't need surgery. What it does mean is theoretically, under normal circumstances, the lower esophageal sphincter is right at the pinch cock of the diaphragm, where the chest meets the abdomen. And that pinch cock provides a little bit of the pressure of the LES, as much as a third perhaps. But you can have a hernia with no reflux and reflux with no hernia. So it's a factor, but it's not enough of a factor to take it to the bank. Interesting question. Can progesterone contribute to respiratory reflux? And aren't a lot of times I can say I don't know, but I've seen about 100,000 patients with respiratory reflux in my lifetime. And I think if progesterone or estrogen were problems, I probably would have heard about it by now. I'm one of those people that I sort of want to know, what else do you want to tell me? Don't tell me about what treatment you already tried. Tell me about you and the questions you have. And these are the kind of questions I get. And to my knowledge, the female replacement hormones don't cause reflux. This is from Jeanette. Jeanette. I've been taking 20 milligrams of miprazole for years, proton pump inhibitor, Prilosec. I have decreased the medicine 3 times a week. I followed your advice and made a lot of changes in my diet. I feel pretty good. I'd like to discontinue the omeprazole. Can you suggest a procedure to follow? Yes. Close the kitchen at 3 o'clock in the afternoon. Put your bed at 45 degrees or sleep in a chair or recliner. Take at least 40 milligrams of famotidine before bed. Use an alginate like Gaviscon, a low-fat, low-acid diet, alkaline water spray, and gum chewing or candy after every meal. That's basically a detox program, and you do it for a month. And by the way, it's not over at the end of the month, because at the end of the month, you can only introduce one thing at a time. What am I going to do? I don't want to sleep so high. Okay. You sleep lower. Wait a couple of nights. Does your reflux return? No. Okay. You want to sleep. You want to eat a little later. Leave everything else alone. Still clean. Jamie diet. So what's true is it takes 3 months to figure out. The hardest part about treating reflux is everyone's different. So you have to figure out, what are the triggers for you. And I don't mean just foods. A lot of people don't have any reflux trigger food, or every food is a reflux food. I have someone who says that the drinking alkaline water gives them headaches and heartburn. The answer is alkaline water is water, okay? It doesn't cause any symptoms, period. So anyway, Jeanette, you need this idea of tapering PPIs. I recommend a detox program, switching over to famotidine, which is generic Pepsid. Famotidine is 7 times more potent as an acid suppressor than Zantac that we used for years. In addition to which, it has none of the drug interactions. Famotidine is the safest, most effective drug in the world, and that's why I wrote the article on famotidine, because all this nonsense on the internet. Some magazine lady went and found anything anyone ever said about famotidine and said, yeah, that's a side effect. It's not. So there you have it. This question, and by the way, if you listen to me here, please sign up for the blog. You put your email in. Each week you'll get just the topic. If you're interested, you open it. If not, you delete it. A very good one was recent. By the way, there's one on 4th of July, eating and drinking, that was posted yesterday. But and how do I know if silent reflux will be next week? But there's one called OTC, over the counter, and so it talks about alkaline water and alginates like Gaviscon Advanced and famotidine, H2 antagonist, not a PPI. So anyway, My symptoms are waking me up with a horrible taste in my mouth every morning. Well, your gums and teeth are going to start to fall out, okay? You have to be eating early and sleeping on an incline, like maybe forever. In other words, they're not little fixes. Like, ooh, if I take this for 6 weeks, ooh, if I do this diet, I'm doing most of this diet and a little bit of that, you know? It's not going to do it. You know, if you have a swimming pool that's not been attended for 20 years, okay, fixing the tarp or the diving board is not going to help. You got a big problem. You need a whole overhaul from start to finish. I have a sore throat, looks very red and inflamed. I also have tinnitus, was consistent, no heartburn and chest pain. Been doing detox for 5 weeks so far, and no change to the symptoms. Again, the same question. Doing one part of a detox program is not enough. People think my diet's supposed to make them well. Nothing below pH 5, only fruits, melons, and bananas. Only meat is poultry and fish. So I understand that what I'm saying now is that there needs to be a paradigm shift in thinking. The 9,000-pound elephant in the room is the American diet and lifestyle. I haven't been to a fast food restaurant since 1980-something. My GI doctor performed endoscopy and found candidiasis. A candidiasis, esophageal candidiasis, and even laryngeal candidiasis is caused by reflux. I had a famous singer from Japan come to me with terrible candidiasis, and it turned out his diet was cherries. He ate cherries. Anyway, acidic. But in any event, if you have candidiasis, you've had long-standing reflux. The candidiasis needs to be treated with diflucan. But in the meanwhile, the underlying problem, remember, that's the rough frame. The underlying problem is reflux. The underlying problem is reflux. If you taste reflux in the morning, bad, okay? If you wake up in the middle of the night coughing, bad. And if you have choking episodes, bad, all right? So all these things are red flags that are ignored by your doctor because the GI is a go-to doctor for reflux, and they know about heartburn and indigestion, maybe. So there you have it. Last question. Jenna, I've changed your name because I don't want to make you embarrassed. Jenna, I'm a professional singer with recurrent flare-ups of LPR, silent reflux. I realize this is a condition all the time. I try my utmost to manage it with a strict regimen around singing and maintaining a healthy diet. However, I still experience flare-ups that create painful reflux in my throat and prevent me from performing, blah, blah, blah. Do you think the motions of singing can exacerbate reflux? No. Okay, reflux is the core. You can't, if you're a professional singer, okay, you need to do everything in your power to get ready to reflux, period. Okay? If it means buying a bed that goes up and down, if it means never eating dinner again, if it means, taking medicine forever, but on Broadway, by the way, this is sort of a thing. Several years ago, we figured this out. When you drink alkaline water, it never gets in your throat, it never gets on your vocal cords, clamps shut so you don't aspirate. But there's pepsin on your vocal cords. If you get on the blog, look for the alkaline water blog with a man that looks like he's made out of water, and you'll see what pepsin does to the vocal cords. And then you'll see these little bottles, which are lovely. Any spray bottle will do. All vocal cord. Why? If you're doing 9 shows a week on Broadway, probably ought to have one of those in your pocket. Well, listen, I've gone over today a little bit. I've covered a lot of material. I've been a little bit more bombastic than usual. But I think there's a moment coming when there's going to be a clash. Maybe it's going to be Dr. Oz and Kennedy. But the American diet and lifestyle is the root cause of most of the disease in this country, and much of it is ignored primarily because doctors think patients are stupid and non-compliant. And it is true, I did a consult with a woman not that long ago, and it ended with her saying, I'm still going to eat chocolate every night before I go to bed. And I said, and you're still going to have reflux every night for the rest of your life. Good luck. So anyway, thank you all. I'll see you next month. Keep on reading. Read my stuff. I wrote a book for you. JamieKaufman.com.